Hi everyone. In this video, we are going to discuss about the genetic disorders. Some of the questions which are asked in our university exam in the topic genetic disorders, like first question is like, what is the chromosomal abnormality found in the Down syndrome, and describe the clinical features of Down syndrome and discuss genetic counseling in the Down syndrome. And about the Down syndrome, other questions like antenatal diagnosis of Down syndrome and ocular findings in Down syndrome, then about the genetic counseling and the USG findings of Down syndrome antenatally. So these are the usual question pattern regarding the Down syndrome. And also, there will be question regarding the Turner syndrome and Klinefelter syndrome. So these are the then also complication to be suspected in a 5-year-old child having Down syndrome with recent onset of gait disturbance. So these are the usual question in the topic genetic disorders that is usually asked in our university exam of pediatrics. So let's first discuss about the Down syndrome. So as an introduction, it is the most common trisomy that is for writing an essay or short essay about the Down syndrome. First, we have to write an introduction. That is, it is a most common trisomy. That is trisomy 21. It is a most genetic cause for the low IQ, and incidence in live born babies is 1 in 733. And associated, we have the cognitive impairment will be the congenital anomalies will be the dysmorphic features will be the in the child. So these are the usual features of the Down syndrome. It is usually asked. That is, by this picture, we can easily remember these features of the Down syndrome. That is, first we already told that it is the most common cause of low IQ in the children. So the mental retardation. Then we have loss at ears. Then epicanthal fold and flat facial profile, and the protruding tongue will be the, and abundant neck skin will be the. Then in the hand, we have the single palmar crease, and there will be congenital heart defects, that is most commonly endocardial cushion defects. Then we have the umbilical hernia, intestinal stenosis, hypotonia, predisposition to leukemia, and gap between the first and second toe, that is dental gap will be there. So these are the features suggestive of the Down syndrome in a child. So, in a question regarding any essay regarding the Down syndrome, if any of these features are present, that is, we have to diagnose it as the Down syndrome. Then about the genetic basis, that is one of the questions about the what is the chromosomal abnormality found in the Down syndrome. That is about the genetic basis of Down syndrome. For that, we have to answer these three genetic abnormalities. That is most common genetic abnormalities: maternal meiotic non-disjunction. That is 95% of the Down syndrome child have the maternal meiotic non-disjunction as the genetic abnormality. And then we have the Robertsonian translocation. That is the 4% of cases we have the Robertsonian translocation. That is most common is the translocation 1421, another is the translocation 2021. Then we have the mosaicism in the 1%. So there are three genetic bases of genetic abnormality in the case of Down syndrome. First one is the maternal meiotic non-disjunction in the 95% cases. Then we have the Robertsonian translocation. Most common is for translocation 1421, and then we have the mosaicism in the 1% of cases. So that is the most common chromosomal abnormality found in the Down syndrome. So that is also a sub-question of the essay. Then about the clinical features of the Down syndrome. Dysmorphic facies, which are the important clinical feature of the Down syndrome child, that is mangled slant of eyes. So by this picture, we can easily remember these features. That is, there will be dysmorphic facies, which include there will be mangled slant of the eyes. That is, there will be an upslanting palpable feature will be there. That is an upslanting palpable feature will be there. Then we have iris, in the iris we have the white spots, like it is also known as the Brushfield's D spot. Then we have the epicanthal fold will be the, that is we have here we have the epicanthal fold will be the, this is the picture which showing the epicanthal fold, that is upper eyelid skin fold which covers the inner corner of the eye. Here the upper eyelid skin which covers the inner corner of the eye. Usually it is not happens in a child, but in the case of the Down syndrome, the upper eyelid skin which fold cover the inner corner of the eye. That is called the epicanthal fold. So the epicanthal fold is a characteristic hallmark of the Down syndrome baby. Then upslanting palpable feature. Then we have the low set small folded ears. Then we have the flattened nasal bridge. Then brush-field spots, that is white spots in the iris. Then we have the short neck. So these are the dysmorphic features. And the skull, we have the brachycephalic, that is flat nose, flat occiput, flat face. So if any in any question, if we found any flat nose, flat occiput, or flat face, it is indicative of the Down syndrome patient. Then a protruding tongue, that is then hypoplastic mandible. So these are the dysmorphic features of the Down syndrome patient. So about the ocular features, we have to write about the epicanthal fold and upslanting of the palpebral features and the brush-filled spots on the iris. So these all should be right in our answer. Then about the other clinical features, we have the musculoskeletal features like in the single palmar crease or simian crease on the hand. Then we have the short fifth digit with the clinodactyly. Then there is a wide gap between the first and second. That is called the sandal gap. Then we have the short neck, short sternum, pelvic dysplasia, and joint hyperflexibility. These are the musculoskeletal features of the Down syndrome babies. So this is the sandal gap, that is between the great toe and this toe. We have a gap between these two fingers. Then this is the single crease, simian crease. Then in the CNS, we have the hypotonia. So by the system wise, we have to remember in all of these clinical features of the Down syndrome babies. That is in the CNS, we have the hypotonia, developmental delay and poor motor reflex. And the CVS, the 50% of the clinical features are due to the CVS, like endocardial cushion defect is most common, then ventricular septal defect, atrial septal defect, and patent ductus arteriosus. Then we have the gastrointestinal symptoms like duodenal atresia, Hirschsprung's disease, ulnar pancreas, and the cutaneous, we have the cutaneous marmota. Then additional features that is in developing like neuropsychiatric like seizures, depression, autism spectrum disorders, and the sensory like nystagmus, strabismus, glaucoma, then cataract and refractive error. So these are the associated features of the or clinical features of the Down syndrome child. Musculoskeletal, there will be atlantoaxial instability, avascular hip necrosis, and recurrent joint dislocations will be there. And endocrine, we have the diabetes mellitus, hypothyroidism, hyperthyroidism, and infertility. And for the extendo-axle instability, we have to screen at 3 to 5 years of age, and the increased risk for the hypothyroidism will be the, and increased risk for the cancer. That is most of the leukemias, that is acute lymphoblastic leukemia, the acute myeloid leukemia, that is less than 3 years. We have to screen for that. So there will be increased risk for the cancer in the case of this Down syndrome child. Then presenile Alzheimer disease, that is 40 years, there will be beta, because of the beta amyloid deposition in the brain, there will be presenile Alzheimer disease in the case of the Down syndrome child. So these are all about the clinical features of the uh, Down syndrome baby. The first one is about the dysmorphic features. That is, remember this picture and write about all the features. Then about the system-wise musculoskeletal, sandal gaps, simian crease, then CNS, CVS, gastrointestinal, cutaneous, neuropsychiatric, and sensory features. Also endocrine. So then increased risk for the cancer, increased risk for the hypothyroidism, presenile Alzheimer's disease. So these are all about the clinical features associated with the Down syndrome child. Then about the diagnosis, we have a screening test and confirmatory test. That is screening test which are usually done in all the pregnant women. That is, we have to do two investigation, that is blood investigations and radiologic investigation. That is usually antenatal USG. And the confirmatory test is by the karyotyping. That is all about the diagnosis. So about the blood investigations in the antenatal period, uh, by this blood investigation, we have to find out the markers from the maternal blood for the chance for the Down syndrome. That is, in the first trimester, we have to test for the double test. That is, which found out the markers like PAP and beta HCG, and uh, and then in the second trimester, we have to do triple test. That is, we have to find out the markers like beta HCG, not the PAP in these second trimester, beta HCG, alpha fetoprotein, and unconjugated estrol. So in the first trimester, PAP and beta HCG, but in the case of second trimester, triple test is done. That is beta HCG, alpha fetoprotein, and unconjugated estrol. And we have to do also quadruple test is done in the second trimester as triple test. That is, along this triple test, we have to find out the inhibin A also. That is the quadruple test. Then interpretation, that is beta HCG and inhibin values increases and other markers values increased in the case, decreased in the case of the Down syndrome child or antenatal screening. Then about the radiological test, these are the USG. This is also asked as the sub question in the essay of the Down syndrome. So there will be radiological test USG findings in the case of Down syndrome child is there will be increased nuchal thickness of the translucency greater than or equal to 3 millimeter. That is, there is increased nuchal thickness of the translucency greater than or equal to 3 millimeter. Then that is the first trimester. Then we have the hypoplastic and absent nasal bone will be the short femur, echogenic focus in the heart will be. So these are the radiological findings. That is the nuchal, increased nuchal thickness, translucency greater than 3 millimeter. Then first trimester, there will be hypoplastic absent nasal bone, short femur, and echogenic fossa in the heart. So these are the USG findings in the antenatal period. Then we have the a combined test. That is, combined test is the first trimester. This is one mark question regarding the test. That is, first combined test is equal to first trimester USG plus double test. So combined test, which means the first trimester USG along with the double test is combined test, and integrated test, which means the combined test along with the quadruple test is the integrated test. And also we have to go for the DNA testing also. Then the confirmatory test, that is by the karyotyping of the fetal material, that is by the invasive testing like chorionic villus sampling, amniocentesis, and rapid test using the fission quantitative PCR is used. The chorionic villus sampling is usually done at 11 to 13 weeks and amniocentesis at 15 weeks. And the rapid test fission quantitative PCR is at the 2 days. That is all about the diagnosis. That is, we have the screening test and confirmatory test. Screening, we have the blood investigation to rule out, to look for the maternal markers of the Down syndrome. Then there are also investigation, that is antenatal USG, and the confirmatory test for the karyotyping. So that is all about the diagnosis of the Down syndrome. Then we have the management and prognosis. The management modalities are the physiotherapy, speech therapy, adequate treatment as and when required, then counseling and prenatal screening and diagnosis. So these are the management options for the Down syndrome child. Then we have to also, along with the management of these conditions or speech therapy or physiotherapy like that, we have to supervise these conditions in the child also. That is, at birth, by a pediatric cardiologist, we have to look for the congenital heart disease. Um, uh, and also the young adults with acquired valve disease. And also in the conditions like strabismus, cataracts, and nystagmus, we have to screen at birth or by the 6 months by the pediatric ophthalmologist and check vision annually. Then this is already, that is the question is regarding that. The question is like that. What is the what will you manage this patient, or what are the management options, or how will you follow up this child? For that, we have to write all these health supervision and all the management options. So for that, continuing with the hearing impairment or loss, we have to screen by the birth or by the 3 months with auditory brainstem response or autoacoustic emission testing, and check hearing 6 months up to 3 years if tympanic membrane is not visualized annually thereafter. Then constipation, we have to screen at the birth, and the celiac disease, we have to screen at 2 years or with the symptoms, and hematological disease at birth and in adolescence or if the symptoms there, we have to screen. And for the hypothyroidism, we have to screen at a birth and repeat at 6 to 12 months, then annually. Then growth and development, at each visit, we have to screen for the growth and development. And the normal, the growth curves are not used here, but they use Down syndrome growth curves. And the obstructive sleep apnea screen at the start at less than 1 year, and each visit, we have to look for the obstructive sleep apnea. And atlantoaxial subluxation or the instability at each visit by the history and physical examination, and radiographs at 3 to 5 years or when the planning to participate in the contact sports. Radiographs indicated wherever neurologic symptoms are present, even if transient neck pain, torticollis, gait disturbances, weakness, many are asymptomatic. And the gynecological care given to the adolescent girls, and recurrent infections screen when present. Psychiatric behavioral disorders, at each visit we have to look for the psychiatric behavioral disorders. So these are the health supervision, the case of the, that is follow up of a case of the Down syndrome child. So it is a recurrent, this is the data showing the recurrent risk. That is, if the woman is having greater than 35 years, there will be 4% chance for the recurrence in the next pregnancy. And if the woman with the trisomy 21 child is already there, there will be 1% chance of the next pregnancy recurrence. Then if the translocation the parent, that is in the translocation the parents is 14-21, that is father is less than 5% and mother have the risk for the 10 to 15% of future pregnancy. And if the translocation is translocation 21-22, father or mother chance is about 100%. So that is all about the Down syndrome. So, and also in the management part, we have to give early stimulation, that is spatial training within 3 months, programs by the child psychologist. And also we have to involve the parents in the treatment by counseling, individualized training and spatial schooling will be provided. And then also the management of the associated complications like congenital heart disease, etc. And there will be support groups, that is Down syndrome society in every society. So we have to report to them. And then the 21st March is observed as World Down syndrome. So that is all about the life expectancy of the child with the Down syndrome is, if no other defects associated, the normal lifespan of but IQ will be about 60 only. So that is all about the Down syndrome. Then we have to go to the Turner syndrome. The Turner syndrome, it is an absence of a part of, this is the chromosomal abnormality of Turner syndrome. There is absence of a part of or entire X chromosome in a female child is called the Turner syndrome. Then it is the karyotype is 45X 0 karyotype in the 50% cases. The structurally anomaly of the second X chromosome with the mosaicism in the, that is structural anomaly of the second X chromosome with the mosaicism in the rest is the chromosomal anomaly of the Turner syndrome. The incidence is 1 in 5,000 live births. The clinical features of the Turner syndrome child, which include, that is a female with the, that is usually in the female, the X is absent, one of the X is absent, part of the whole of the X is absent. A female with retarded growth with a short stature is the major clinical feature of the Turner syndrome child. And the systemic features like general, we have the short stature, neck, webbed neck and the low posterior hairline. Then in the mouth, high arched palate and micrognathy. In the eyes, we have epicanthal fold similar to that of the Down syndrome, but that does not confused with them. Then ears, we have the hearing impairment, chest, shielded chest or the broad chest, and widely spaced inverted nipples. Then skin and nails, lymphedema of the hands and feet, alopecia, nail hypoplasia. Limbs have the short stature and cubitus valgus deformity. In the endocrine, hypothyroidism and heart disease, we have bicuspid aortic valve. In the kidney, horseshoe kidney. In the gonads, no pubertal development and infertility will be present. And also there will be psychological problems in the Turner syndrome child. So that is all regarding the Turner syndrome. And then we have to investigate this Turner syndrome child, whom to screen. All the pubertal short girls should be, all the pre-pubertal short girls should be screened for the Turner syndrome. And girls with the primary amenorrhea is also should be screened for the Turner syndrome. Routine investigations like a CBC and ESR should be done, RFT and LFT to rule, and also serum calcium and serum alkaline phosphatate to rule out other causes of the short stature. So usually the major clinical feature is short stature in the girls, prepubertal girls. So we have to rule out other causes of short stature in these girls. Then TSH and T4 to rule out the associated hypothyroidism, and LH and FSH. If there is increased FSH and LH points to hypergonadotrophic hypogonadism in this female, then USG pelvis to rule out the hypoplastic uterus or the ovaries, and confirmation is by the karyotyping, that is 45X0. Then management is, first we have to management of the short stature, that is we have to monitor the height, and growth hormone therapy is beneficial. Final adult height increases by about 12 centimeter by the 7 years. Start at a young age for the good response, and oxandrolone with the growth hormone in the resistant cases we have to give. Then by after the management of the short stature, we have to evaluate for the associated hypothyroidism and treat accordingly. And the management of the hypogonadism, we have to give the estrogen replacement therapy. It should be started at 12 years after 3 years of growth hormone therapy, and we have to give 50 to 100 nanogram per kilogram per day and increases gradually the dose. After 2 years of treatment with estrogen, bleeding occurs and progesterone 5 to 10 milligram added to induce menstruation. So that is the management of the hypogonadism. So that is all about the management of short stature, and the evaluate for the associated hypothyroidism, and also management of the hypogonadism. That is all the treatment modalities for the Turner syndrome. Then about the prenatal diagnosis, the risk of recurrence is low, so not done routinely. The prenatal diagnosis of Turner syndrome is not done routinely because of the low risk of recurrence, and increased nuchal transparency and high drops on the USG is a feature of the prenatal, helps in the prenatal diagnosis of Turner syndrome, and that is confirmed by the CVS or the chorionic villus sampling or amniocentesis. That is all regarding the Turner syndrome. Then about the client, so that is all regarding the Down syndrome and the Turner syndrome.